This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. This is Matt Smith. I've got my colleagues Nicole Rich and a new recruit to Audible Bleeding, Adam L. Mosley, who is a chief resident at Cornell, who's going to be joining the fellowship at New York-Presbyterian, Columbia, Cornell in a little over a year. And today we're excited to have Dr. Andrew Meltzer on with us. Dr. Meltzer is an associate professor of surgery and chair of vascular surgery at the Mayo Clinic in Arizona, where in addition to a busy clinical practice, he researches cost drivers in medicine, along with safety and efficacy of new technology in vascular surgery. Dr. Meltzer received an undergraduate degree from Yale, completed his medical school at Jefferson University in Philadelphia, which was followed by a general surgery residency at the Massachusetts General Hospital in Boston, and finally a vascular surgery fellowship at New York-Presbyterian Hospital, Columbia, Cornell, where he stayed on faculty there at Cornell for 6 years before his appointment at the Mayo Clinic in Arizona. Welcome, Dr. Meltzer.
Thanks very much for having me.
So we'll go ahead and just dive right in. Can you tell us what inspired you to go into vascular surgery?
Vascular surgery for me was almost a little bit of an accident. I was dead set on going into cardiac for most of my training. Spent 2 years doing heart and lung transplants in pigs and baboons when I was in the lab. But when I came out of the lab as a fourth-year resident, had the opportunity to rotate again on the vascular service and realized that for me it really combined a lot of what I did enjoy from my general surgical training, as well as what I liked about cardiac. And also I think 2 years in the lab and really starting to think about a career trajectory and what opportunities would be available. I was excited about vascular in that there was still really an opportunity to advance the field. So much ongoing change and potential for an evolving specialty, which at that time, at least, cardiac surgery was not in the same position. So all of that really combined, and just a great experience on Cambria's service at MGH and working with the group there really compelled me to change course, and I was sort of a late arrival to the vascular scene in that regard.
Dr. Meltzer, this is Adam L. Mosley. Thanks for joining us. So you trained at the Massachusetts General Hospital during an era where there was a number of prominent vascular surgeons there. Do you have any mentors that were particularly influential during your training at that point or later?
Everyone there was great. Obviously, Cambria had a particularly unique practice as now as an attending for some time. I can appreciate. I learned a lot from Glenn LaMoraglia as well. I mean, he's a great surgeon and a great doctor on top of that. But certainly the entire service was an exciting place to be. I'm still very very close with a lot of my fellow trainees from that era, and a lot of the fellows that had come through while I was a resident. People like Jim Black and Stone and Stoner, people that I'm still very, very close with today.
Hi, Dr. Meltzer. This is Nicole Rich. So I know a lot of your research revolves around cost drivers in medicine and surgery. How did you develop that interest?
So I got into this fairly recently. I think through most of my training and research experience after I got out of the lab and realized that I wasn't going to be a basic scientist. I wanted obviously to focus on clinical practice, and at that point got involved in outcomes research and using large databases and trying to do a lot of the work that's become increasingly popular with those sorts of data sets. Recently, I guess about a few years ago, I decided to spice things up a little bit and started pursuing this MBA, which started when I was at Cornell and then transferred to the U of A once we moved. And, fortunately, I'm wrapping that up in a couple weeks, and looking forward to getting my degree. And I think that it's done a few things for me at this point. One thing for sure, I think being on that path really helped me move into a leadership role at a relatively early stage in my career. But beyond that, it's really opened my eyes in terms of expanding the way that I, as a surgeon, look at a lot of these research issues and change the questions that I ask. Certainly, we talk a lot about effectiveness, and there's certainly some good work that's been done looking at cost effectiveness of what we do. But I think that having that kind of adult educational experience of going back and thinking about economics and thinking about accounting and applying that to a relatively mature career at this point has allowed me to really start to address some questions with at least a little bit of expertise that go beyond just thinking about effectiveness and even cost effectiveness, but thinking about the structure of our reimbursements and thinking about this huge area that we're in. I mean, it's interesting because on the one hand, we're dealing with it day to day in the trenches, and we hear a little bit about healthcare costs from our patients, and we have a general idea about how expensive all of our fancy stents are. But we don't really think a lot about that and frame it in terms of everything that we hear on the news about how expensive healthcare has become and what's driving those costs, and how, in some respects, the way that our specialty, which, quite frankly, delivers a lot of high cost care that at times is only marginally effective, contributes to this issue. So I think that, really it's been a little bit of a transition for me as I've just tried to start to think a little bit broader and ask some research questions that are informed by this additional education that I've received, and go beyond just looking at outcomes and patency rates and freedom from reintervention and the sorts of things we talk about meetings, and really start to frame these issues in terms of larger questions and how we as vascular surgeons and what we do all day to day contributes to this, these massive healthcare expenditures and this whole economy that accounts for 17% of our GDP at this point.
And Dr. Meltzer, what do you feel some of the biggest cost drivers that you've been mentioning in healthcare are?
First and foremost, the biggest issue, and what's really shocking, is this whole idea of the administrative costs. It's certainly something that any of us, who work in a hospital see day to day. The number of administrators relative to physicians has gotten just preposterous. I think that in the last 30 years or so, I think that there's been a 2,500% increase in the number of administrators relative to the increase in physicians. And a lot of the costs that are associated with our healthcare enterprise are a result of this. I mean, if you think about, administrative costs aren't just the administrator salaries. It's the idea that, one of the byproducts of the way we pay for healthcare in this country, and having all these different payers and different stakeholders means that all needs to be sorted out. When, if you do a case, the charges for that case are handled by full-time employees at the hospital, and those are different from the full-time employees that are handling the hospital side charges. And every time that you have to deal with someone on the phone to get prior authorization to do a procedure, I mean, these are all layers upon layers of administrative costs that have become a part of our healthcare system. It's not even necessarily a political question, but certainly it has become one. But I think one of the issues when people talk about a single payer system and how that could be beneficial, regardless as to where you are on the political spectrum with respect to that idea, it's certainly true that if there were the opportunity to eliminate much of this administrative burden, that would dramatically improve healthcare costs. I think the estimate, depending on what you read, is somewhere between 20 and 30% of healthcare costs can be attributed to administrative costs. So that, I think, is the biggest driver, at least that we ought to all be aware of and think about. Recently, I've been looking at a few different issues that are a little outside of what would normally fall into the framework of traditional outcomes research, and delve more into these sort of economic and cost issues. One that I'd become interested in several years ago is the way that defensive medicine drives up healthcare costs. And I wrote a paper several years ago, I think actually when I was still a fellow, looking at variation in IVC filter use at the state level. And if you look from state to state, and even after you adjust for differences in the prevalence of venous thromboembolism and other comorbidities, there's tremendous variation when you look across each state in terms of the rate of IVC filter use relative to the prevalence of DVTs, which doesn't really make a lot of sense. And so in writing that paper, I was trying to come up with some sort of explanation. And so I linked the state level data that I had to some other databases, trying to figure out if there was any correlation with kind of non-clinical factors. And what's interesting is that when the one thing that proved particularly predictive of high rates of IVC filter utilization was an adverse medical legal environment. It's something that I've become more interested in lately, and kind of revisited some of that research and looked a little more broadly at our specialty and at healthcare overall, to learn a little bit more about defensive medicine and how that drives up healthcare costs. The second area that I think is interesting and is also become a research focus is overutilization. So there's obviously tremendous variation in healthcare delivery, tremendous variation in treatment intensity, and it's something that's been well explored by some folks in our field, like Phil Goodney and his colleagues at Dartmouth, who, because of the Dartmouth Institute's support, have done a lot of work looking at variation in utilization of different vascular services, and brought it a little bit more into our world. But clearly, when you look at geographic variation, at variation in treatment intensity based on socioeconomic status, there is tremendous differences in terms of how people are treated in this country, and how much is spent on their healthcare. And I think that vascular has been particularly susceptible to this because we have a fee-for-service system, and a lot of what we do reimburses very well. And some of the things that reimburse very well are very easy to do. So there are some areas like vein ablations, IVC filter placement, at least until fairly recently, was another one of those areas. And certainly a lot of the proliferation of moving many of these endovascular procedures into outpatient, physician-owned endovascular suites has moved these things out of the hospital and created a situation where there's the potential for overuse. And we've looked a little bit at this variation in utilization, and I think that certainly, it's a fee-for-service system that encourages payment based on the number of procedures that can be performed, has allowed many people to do very well doing some of the vascular procedures that we all do every day.
So it sounds like from what you're saying, there's a few different tenets to the major cost increase overall in healthcare. And the first one you mentioned is administrative burden of cost. The second one you mentioned was the medical legal climate of the area you're practicing in. And the third one you mentioned so far is procedure overutilization. I want to go back to the medical legal aspect that you were discussing, and you were alluding to the idea of defensive medicine and how that plays into what we do and what it costs. Can you just talk to us about what defensive medicine actually means and how it can directly impact the healthcare costs?
So broadly defined, we would say that defensive medicine is any time that you order a test or do a procedure that you're essentially compelled to do so or influenced to do so because of the fear of being sued. And so it's obviously it's a tough figure to put a number on, but there's been various studies across specialties that have looked using physician surveys and really just ask doctors, what percent of what you do is, because you feel like you need to order that additional CAT scan, or you feel like you need to put an IBC filter in that patient because, if you don't, you might get sued. And it obviously varies, but 20% is a reasonable number. There actually was a recent survey of hospitalists that was kind of staggering, but it demonstrated that hospitalists identified that 37% of the tests that they ordered and the care that they felt compelled to provide were really due to defensive practice. So that's kind of broadly speaking, it's a huge number, and it's something that I think as physicians we need to be aware of, primarily because you never really hear much about it anymore in terms of any of that healthcare reform debate. I think a lot of that's because the trial lawyer lobby is so strong that a lot of these efforts to curtail it, although it would certainly be in physicians' best interests, and it would be in the best interest of controlling healthcare costs. It's tough to get these issues onto the chopping block in terms of reducing healthcare costs.
That was a really interesting connection that you made between the medical legal environment and the costs and the amount of defensive care that's being practiced. Do you think that we've got a role as physicians and as vascular surgeons more specifically to be involved in making this information more widely known or advocating for changes in the healthcare system?
I certainly think we should, because if we don't, no one else is going to. I mean, and I've tried to take it a little bit further and look specifically at a lot of the vascular care that we provide. So if you look at some selected vascular DRGs. Now, granted, I loaded the deck a little bit when I did this work by specifically picking out some of the DRGs that I thought had, were sort of particularly litigious, like those DRGs that apply to amputation or pulmonary embolism diagnoses like that. What's interesting is that when you look at the Medicare data in terms of payments, the average payment per patient per state by DRG, it's the medical legal environment that ends up being more predictive of higher costs than even the prevalence of various comorbidities and variation in socioeconomic status. So I think it really, it is something that impacts many of us day to day. And I think that, to your question specifically, I think that, we do have an obligation to be aware of it. It's something that we should be actively lobbying for. As I said, it's something that if we don't take a stand on it, that no one else is really incentivized to do so.
And aside from the kind of global tort reform type issue and the much more personal, I'm just not going to practice that way, is there anything that you've seen or that you think we can do as either as a society or as a group or as a practice to improve this?
I think it's hard because I think until there's meaningful tort reform, it's hard to position oneself as an outlier and say, well, in this climate, I'm going to take a stand and not order that CT scan or not put that filter in because I feel like the impetus to do so is driven by non-clinical factors. I think that obviously there's an advocacy arm to the SVS that should be looking out for our issues. And I think that for all of these professional societies, it's something that we really ought to address. I mean, if you look at the impact of tort reform, there's been studies in the cardiology literature looking at the state level in states where they've implemented tort reform or caps on medical malpractice payouts. And what they've found is that the use of some diagnostic studies and the prevalence of cardiac catheterization ends up decreasing dramatically after in the same states after there's some cap on malpractice payment, and essentially that physicians feel less compelled to do studies if there is a more favorable medical legal environment.
Right around the time that you were transitioning from New York down to Arizona, I know you published a very interesting paper on vein stripping or vein procedures and who was doing them. And one of the more interesting things you noted in that paper was the number of veins that was being targeted based on the training. Can we use that to target or to transition a little bit over into overutilization? Can you give us the rundown of that paper and some of its implications?
Sure. So, I think that overutilization in general is something that is an issue in our field. If you look at the variation in the spread of reimbursements to vascular surgeons, there's a huge range, and there's a small proportion of vascular specialists that bill huge amounts to Medicare for the procedures that they perform. I have one of the Mayo residents presented some of this work at the SCVS last year, and he refers to it as the vascular 1%. Basically, there's about 3,000 vascular surgeons in the country. And so the top 1% of Medicare billers is basically about 30 surgeons. And those 30 surgeons account for roughly 12% of all Medicare payments to vascular surgeons nationally. We're looking into this in a little bit more detail, but it gives you the idea of this huge spread in terms of reimbursement. Some of this was inspired a little bit by a New York Times piece a few years ago that brought this really into the lay press when the Medicare provider utilization data became publicly available, and you could go on the internet and look up any physician in the country and see what they had charged to Medicare and how much they had been paid for those services. So what we did with the vein utilization paper was expand that concept a little bit more and take a procedure that many people are doing who don't necessarily have any vascular training. I mean, certainly back in the day when the only option was vein stripping, a more invasive procedure, this was something that was well within the purview of vascular surgeons. But obviously, as vein ablations have become less invasive and increasingly lucrative, it's become something that really anyone can do. These outpatient vein centers are popping up everywhere, and there's a reason why there's a vein center right down the street from Cornell and right across the street from a lot of other major academic medical centers in this country. It's because it's incredibly lucrative to have a physician in there pressing the button on an RFA machine and recouping a significant windfall every time one does so for a relatively minor amount of work. And so essentially had the hypothesis that there would be some variation in the treatment intensity and utilization of these procedures based on whether or not someone really had training in the vascular space. And so we came up with the idea of this utilization index, which is basically the number of vein ablations per patient per year. And when you look across the country and stratify by specialty, vascular surgeons actually have the lowest treatment intensity. And as much as we kind of like to blame cardiology and interventional radiologists for everything that's wrong in vascular surgery, in reality, those specialists who also have in their training it encompasses some aspects of vascular disease, and it's I would say it's certainly reasonable for them to be providing venous care, are relatively comparable to vascular surgery in terms of their treatment intensity. Where you see people doing significantly more vein ablations per patient per year are those specialties that really have no training in vascular disease. You've got anesthesiologists, family practice doctors that are doing vein ablations, and they're doing it with far greater frequency and much more commonly in any given patient than vascular surgeons are. So to put this utilization index kind of in context, vascular surgeons, on average, a vascular surgeon who treats Medicare patients does about 1.5 vein ablations per patient per year. There are people out there that are doing, on average, 3 vein ablations per patient per year. And, it's not really explained by a variation in disease prevalence. The drivers are specialty and whether or not one is working in an outpatient facility versus an inpatient setting. And some of the some of the biggest, I think the biggest offenders were preventive medicine. Ironically, if you're a preventive medicine specialist doing vein ablations, you have some of the highest utilization index. Gynecologists. So, it's kind of staggering, but again, not really surprising because we know what's going on, and it reflects the fact that we do have this fee for service model where anyone can kind of get trained up in doing some of these simple vein ablations and enter into a situation where it's really driven more by the financial benefit to the physician rather than optimizing the care of the patient.
So, Dr. Meltzer, aside from vein procedures, can you give us some other examples of overutilization in vascular surgery, and also any insight you might have into the prevalence of complications or harm that are caused by this overutilization?
There's some data that's certainly out there, and I think that the New York Times article from, I want to say 2015, really was an attempt to provide something of an expose on this. But look, the reality is there are, I think that certainly although, and this will certainly be controversial, but the reality is there's a reason why everyone's interested in opening up an outpatient endovascular suite and taking care of these patients with peripheral vascular disease in the outpatient suite that they own and can collect the facility fee instead of doing the procedure in the hospital. And I think if you look at the outpatient reimbursements for some of these atherectomy procedures, and it's really staggering. And, on the one hand, at a systematic level, it may be beneficial from the standpoint of avoiding some of those hospitalization costs and the charges associated with taking care of those patients in the hospital. But I think the obvious concern is that it really allows for profit-seeking behavior to dictate the volume of those patients. Now, in terms of the safety of the procedures, it's tough to say. Certainly, it's kind of like doing those asymptomatic 60% carotids. The outcomes are usually pretty good if patients don't need anything done. So it's tough to totally pin it as a safety issue. But I think it's something that we do need greater oversight on, and it's something that we need to be honest with ourselves about whether that's really the best model in which to take care of these patients.
Dr. Meltzer, the fee-for-service argument, the fee-for-service applies to vascular surgeons also, including academic vascular surgeons. Do you think it's more of a fee-for-service driving all this, or do you think it's a lack of understanding of the pathology and what's actually going to help the patient in these non-vascular trained specialties? And by that, I mean not IR, not IC.
Most of us are well-intentioned and want to do the right thing for the patient. And I'm sure that, if we polled those 30 surgeons that comprise the vascular 1%, the reality is that they would all tell you that they're good doctors and they're doing the right thing, and and quite frankly, many of them are names that you would recognize. The issue becomes that in a model where we are incentivized for the work that we do, it's somewhat of a problem. And I think even if you're not explicitly going out and doing unnecessary procedures, there's just on a day-to-day approach to practice, if there's an implicit situation where one is being financially rewarded for doing more, that we're going to do more, and we'll find ways to justify it both externally and we'll find ways to justify it to ourselves. For me, it's been interesting. I've always been salaried, both when I was at Cornell and now at Mayo. So I've never been really sort of explicitly incentivized, in the way that I might be might have been if I had been in a private practice type of environment. But I will say that, one aspect that has been really interesting to observe is that with this so-called Mayo model of care, where really there's, a significant emphasis on simply doing the right thing for the patient. And I feel as if my volume and my reimbursement and what I'm charging is my RVUs are not really tracked in a way that they are most commonly, and at other facilities. And I think that I've definitely seen it in my own practice. I think I've become less aggressive with claudicants. I think I've become less aggressive with asymptomatic carotid disease. And I think even though I don't think my overall framework or approach to patient care has really changed, I think that there is a difference in that, I don't have a monthly meeting with the finance folks to go over what I build. I don't get those reports, at a personal level. I obviously, as a division chair, I kind of see those numbers, but it's not something that, the goals are to improve patient care, to be safe, to provide a good patient experience. It's not purely about just growing volume. And I think that that's really the issue, is that as long as we're going to have a fee for service system, there is this implicit reward to do more. So given the option of putting in an SFA stent or really trying an exercise program, unfortunately, we're in a situation where most vascular surgeons in this country will have some secondary gain from taking a more more aggressive approach to those patients. And I think that drives up the cost of care in our specialty and across the system. It drives up the cost of care everywhere.
So switching gears just a little bit, I think a component that we haven't discussed yet in the realm of costs, especially in vascular surgery, is device costs. And I think we function in an environment where we depend a lot on medical devices, especially ones that are very expensive in the realm of aortic surgery, where a device is $15,000 or $20,000, in a market also where there's limited competition and certain companies can control the majority of the market. Can you just kind of give us the rundown a little bit on device costs, how they work, how they've evolved, and what we can do about them?
So I call this the endo-oligopoly. And again, this is another good example of kind of how my business school has kind of shifted the way that I think about some of these issues that as a clinician we just kind of take for granted every day. But so an oligopoly market structure is when you have a small number of firms that make that are in the market. Usually there are very high barriers to entry. And oftentimes, and is generally the case, what happens with an oligopoly is that the firms don't actually compete with each other on price. They market different areas of differentiation. So kind of the classic examples, the airline industry. And really, if you think about our aortic endografts, it's kind of the same thing. The FDA places these tremendous restrictions on companies that would want to enter the market. And as a result, if you look back over the last 20 years or so, it's really the same people selling aortic stent grafts today that were selling aortic stent grafts when they first became available. And what's interesting is that those device costs account for over half the total procedure cost at the hospital level. And when you actually look back, one of my current partners, Sam Money, 20 years ago wrote a paper looking at device costs specifically for aortic endografts. And when you adjust those numbers for inflation, the reality is the device costs have actually gone up a little bit compared to where they were back in 2000. So I mean, here we have this technology that's maturing, and the reality is that the the firms that are selling these devices to us are basically just charging exactly what they were 20 years ago, and that's because there's a situation where the regulatory barriers prohibit new entrants to the market, and also there's sort of this implicit understanding that the device companies don't really compete with each other on price, right? So when we as vascular surgeons kind of talk about this stuff, we sit around and we debate, suprarenal fixation, and I like that delivery system, and it's a little bit smaller, and this one, this is better for this particular neck and that sort of thing. And they've it's the classic oligopoly situation where they've established their points of differentiation, and they've marketed their devices based on these non-price issues. And then they all cost, exactly what they did 20 years ago. And, it gets a little worse actually, because the arrangement is such that in most hospitals, when they enter into contracts with the device companies, someone from the hospital, it's of course not the surgeon, but someone from the hospital is to sign a non-disclosure agreement. So almost across the board, you're actually not allowed to, hospitals are really not allowed to disclose what they're paying for these devices. And this is just another way to reduce the competition, because if I don't know that you're paying less than me, I can't go to the manufacturer and complain about that. And although it would be really bad press, I don't know if there's an example of a hospital being sued for breaching that sort of contract, but they have gone after the consulting firms that kind of aggregate that data and try and help hospitals negotiate better contracts for these device prices. So the manufacturers have sued consulting firms for that issue. So I think it's an interesting situation when you kind of take a step back from it and really think about those costs, because I think with all the interesting cost effectiveness of EVAR in particular, our bias as clinicians is to really try and focus on the effectiveness side of the cost effectiveness issue, right? So when we start hearing that EVAR may not be cost effective, we start thinking about late endo leaks and conversions and reinterventions and all this sort of thing. But the reality is that the big expense is an upfront expense for the device that hasn't changed in 20 years. So I would say that we probably ought to be less focused on the effectiveness, because I think that certainly the overwhelming majority of aortic aneurysms are being treated with an endovascular approach, and that's not going to change. But we have to really kind of refocus ourselves on what we might be able to do to decrease the costs and to figure out a way to reduce these device costs.
So it sounds like this gets us back to being involved in the policy that's involved in how the prices are negotiated between the device manufacturers and the hospitals. Do you think that there's a role for vascular surgeons there, or do you have other ideas about how we could be more involved in this whole process?
I think like anything else, the first step is just awareness. Until I really started to look into this, it wasn't something that I had thought about in this way. And so my hope is that just by increasing some awareness and encouraging my colleagues to think about some of these cost issues and to think about device costs, that somehow that this will open some dialogue and open some opportunity for us to be more involved in some of these discussions. Because truthfully, I'm very much a capitalist, and I'm not suggesting. I'm not suggesting that somehow there should be controls on these prices overtly or anything, but I do think quite the contrary. I think that a lot of this behavior one could really consider as anti-competitive. And the fact that I don't want to. I don't know if I want to go on the record and use the C word, meaning cartel, but it's really one could make an argument that it is a little suspicious that these devices really all cost more or less the same, and there's been no real move for any of the major manufacturers to take a stand and say that if cost effectiveness of EVAR is an issue, then we'll reduce our costs and try and sell more devices. And the problem with doing that is that in an oligopoly, that just doesn't work. I think personally, I think we need to be very vigilant of the FDA. I think that a lot of these barriers to entry that have been supported by the FDA are actually not necessarily providing the best service to the American populace and to our patients. There's a economist who's at the University of Chicago and won a Nobel Prize 30 years ago, I think, by the name of Stiegler, who wrote about this concept of regulatory capture. And it's basically when you have a federal agency that's charged with protecting the consumer from business, but it ends up essentially just protecting the interests of business. And I think that's basically what happens with the FDA. How many times have we been told by our friends in industry how we really want to get this device to you, and we really want to do it, but we can't. Well, the reality is that new entrants to the market and a greater diversity of options in terms of how to treat these patients would actually erode these 80% margins that the current manufacturers enjoy, because there would actually be some real competition in the marketplace.
That's fascinating and a little bit aggravating to think about all that. And
to get to your point, I think that knowing about it and thinking about it is the first step. Certainly, I think a lot of the issues that I'm talking about are things that, it's not issues that we necessarily might be well positioned to take action on as vascular surgeons, but things we need to know as citizens and just as voters. And I think that's really the first step. And then beyond that, something that we look for opportunities where we can find them to change the system a little bit.
I think that's an excellent overall message. You've given us a lot to think about. We have a couple questions that we like to ask everybody towards the end of these interviews, if you'll humor us. The first one is there anything that you feel is one of the most exciting things in the near future of vascular surgery?
I think that we're moving more and more towards really just being able to provide less and less invasive solutions to patients. And maybe it's a little trite, but I think that it's fascinating to think about. I think certainly endovascular arch work is really exciting. I think that the capacity to treat more and more complex aneurysms with a totally minimally invasive and often percutaneous approach continues to be exciting. I think these are the patients where there's really a potential great benefit, not just in terms of outcomes, but in terms of quality of life. So I think that it's going to be exciting to hopefully get there in the next several years.
Dr. Meltzer, we're curious what your stance is on Paclitaxel technology.
I would refer you to my Paclitaxel Gate lecture, some of which I think is probably available on Google and on some of it referenced on social media, thanks to some of my friends and former fellow Jeff Syracuse. I think it's another, to use your term, Matt. It's frustrating because I think that, again, it's a situation where we have allowed ourselves to be sold a bill of goods here. So short answer to your question is I see no reason to use paclitaxel based technology in any patients for any reason in terms of treating peripheral vascular disease. I think the fact that that it's still even available just speaks to the enmeshment between the FDA and industry. And I think that there are plenty of other alternatives, including surgical ones that provide comparable effectiveness and safety that should be considered long before one starts putting paclitaxel into people.
I do recommend that the listeners check out Dr. Meltzer's talk on this topic that we'll put in the show notes. It's very entertaining, very educational. I think another question that we like to ask everybody who comes onto the podcast is, do you have any tricks in general or anything specifically that get you out of trouble in the operating room?
The biggest tip is not to get into the operating room if you're know when not to go. I think that that's certainly the hard part that you don't always learn when you're training, because particularly if you're in a busy clinical program, you kind of see the end result. You see the patients that are booked, and you see the patients that make it to the OR, but you don't always see that denominator. You don't get to see the patients that someone with years of experience looked at and said, you're getting an exercise program, or you're not getting fixed until this is over, 6 centimeters. I think that, again, it's a ringing endorsement for all the trainees to go out there and get to clinic and see what that denominator looks like, and which patients are kind of being pushed away from surgery at the get-go, so you don't just show up for your first day in the office as a new attending and think that every patient should undergo surgery. Beyond that, I'm very fortunate right now in terms of tips to get me out of trouble in the operating room. We've got a great group, and I've got great partners, and we function very much like a team. And we kind of have a open door policy with each other's OR. And if someone's been down there for a few hours, and we usually pop in and kind of check on each other, and certainly we're all always available to help each other out. So I think that the best advice I can give is to find yourself a situation like that when you're first starting out, and it's always a good idea to phone a friend, whether it's getting opinion about how to tackle a case preoperatively, or just to get another set of eyes or a set of experienced hands if things aren't going perfectly in the OR.
Great. I will concede that clinic can sometimes be educational and fun.
All right, last and most important question, Dr. Meltzer, what do you listen to in the operating room?
Well, that's a good one. So one of my major initiatives as the division chief was to implement a vascular surgery Pandora account to facilitate intraoperative music, and it's great because we've got a dynamic practice with my partners of kind of spanning the career spectrum. So everyone's kind of got their own picks. I've learned that you kind of have to let the nurses run with it a little bit. Otherwise, you're going to have a very unhappy people in the operating room. If it were up to me, I would just listen to old Grateful Dead shows in their entirety. But I will tell you, as a general rule, people do not like that. If you can put together a team that appreciates that sort of thing, it's great. I actually just recently found out that apparently I am they either so on our Pandora station I'm either they put in either classic rock or hipster barbecue, I guess. So, short answer is apparently I'm hipster barbecue is what I listen to, and it's pretty good. So I encourage all of you to go check that out.
I'm gonna have to try it. Well, thank you very much. This has been a very exciting, engaging conversation. I think our listeners will really enjoy it. Thanks again, Dr. Meltzer.
Thank you, guys.
We are Audible Bleeding, the vascular surgery podcast. We'd like to make our listeners aware that there are still a few spots left to register for the Big Apple Boot Camp in New York City, New York, on September 19th to the 21st. This is a 2-day skills course intended for first-year vascular fellows or third or fourth year integrated resident. For more information on how to register and who to contact for more information, click the link in our show notes.